So let's go a little bit more in detail about the indications for colorectal surgery performed laparoscopically. We have talked about the short-term advantages just a few minutes ago. Patient safety is a major issue, and we have talked about the fact that there's less complications, less mortality in certain aspects, certain populations at least. Even in the high-risk patient we saw, and the fact that laparoscopic surgery does contribute to lower morbidity and mortality is no longer a question of doubt. There has been an issue about the survival aspect, and that most of the publications do not give any advantage to laparoscopic surgery as concerns survival, except for the study that was published by Lacey in 1993, where they actually came up with the conclusion that cancer-related mortality was better in the laparoscopic group, 9%, as compared to the open group, 21%. And they said that Lacey said that the laparoscopic approach actually seemed to improve the long-term outcome of patients with colonic cancer. They said that difference was probably due to the fact that in the stage 3 tumors, that they showed that survival was better. And I don't have the time, but if you want, I can show you the actual results of that study. The problem was that the methodological aspect of that study were debatable. And it was shown later in publications that the actual survival benefit that they purported in stage 3 cancer was due to an artifact of the methodology rather than an actual survival benefit. And in any case, none of the ulterior publications on the topic have ever been able to confirm that the laparoscopic surgery was better in terms of long-term survival. The only thing that has come out of the literature and has to be said with solid methodology behind it is that the carcinologic outcome is at least as good or is not worse with laparoscopic as compared to open surgery. This is the main point that has to be made. So the indications for laparoscopic surgery have evolved over time, and laparoscopic surgery has taken over many aspects. And one of the major contributions that we will talk about in another talk is the contribution that has occurred with what we call complete mesocolic excision, or in cancer of the rectum with complete mesorectal incision. Sorry for the overlap of the photo. You will see that you will remember that one of the major advantages of laparoscopic surgery was better surgical planes. And this has really put the emphasis on the fact that total mesorectal incision first and then total mesocolic excision afterwards have become a major advantage of laparoscopic surgery and have taken over the indications for those two aspects of laparoscopic colectomy. Further to the indication of laparoscopic surgery is an issue concerning the phenotypes, because most cancers related to chromosomal instability and mutations. Now, a lot of literature today is concentrated on this aspect, the cytokine or the chromosomal aspects of cancer today are really very much on the tip of the tongues of every surgical publication, or lots of publications today. And they have become major issues in the guidelines on oncology, mainly in the United States, but also in Europe. I'm not so familiar with the Russian literature on that aspect, but certainly this is something that's going to be a future topic, a major topic. So the chromosomal phenotypes of cancer are something that are of major importance. The oncogene mutations, the RAS oncogene mutation, the cross mutation, the BRAF mutation are something that is really major to the responsiveness of chemotherapy, even though they represent at the most 1/5 of the patients that we operated on. These mutations are something that have to be looked for, and there is a major move today that the genetic aspect of tumors be reported in a routine manner, whether we're talking about the biopsy, the preoperative biopsy, or especially the specimen. When the specimen is investigated, the phenotype, the chromosomal phenotype has to be clearly indicated, because this has a major consequence on the prognosis and the need for adjuvant chemotherapy. The contraindications for laparoscopic surgery are very classical. I'm not going to insist on them. We have come to some of them beforehand. The major contraindications related to the patient are related to issues such as patients that are not able to tolerate general anesthesia, or patients that have problems with coagulation, in other words, a coagulopathy that is not correctable. They also can be related to, for instance, deformities, physical deformities that make it impossible to put the patient correctly on an operating table, which contraindicate or make the access to the abdomen difficult. These aspects are rare, but still have to be considered. The other aspect is in cancer is the problem that is related to T4 tumors. T4 tumors are no longer a contraindication to laparoscopic surgery. They do require, however, a specific maneuvers and specific precautions that have to be considered and taken into consideration. This is a paper that looked at the safety laparoscopic surgery when talking about T4 cancer and coming out of Korea. But the same papers have been published worldwide, and notably Parul Shukla in the United States in Annals of Surgery wrote papers also, although not as methodologically sound as this paper from Korea, that show that actually disease-free survival and overall survival are completely comparable between the open and the laparoscopic aspect, and should not be a contraindication to surgery. This collaborative study from Korea involved 245 patients, 128 with right, 128 with undergoing laparoscopic surgery for right colonic cancer, compared to 117 in the open group. And all patients went curative surgery for histologically proven T4 adenocarcinoma. The study was published in 2019. The study was closed in 2013 because the primary endpoint was 5-year disease-free on the left and overall survival on the right. They did look also at some secondary endpoints, which included the rate of R0 resections. So in the study, overall study, of 224 of those T4s were N0, and 359 of those tumors were N plus. The median follow-up was just under 5 years, 53 months. So the postoperative morbidity was lower for laparoscopy, 12.5% versus 22.2%. No difference in the R0 resection rate, 94% versus 96%. The 5-year disease-free survival and the 5-year overall survival rates were lower for laparoscopy. However, the difference was not statistically significant. Another major aspect of this paper was that the rate of postoperative complications were not statistically significant as well. And the conclusion was that laparoscopic surgery was safe for patients with T4 cancers, but requires specific consideration for those that, especially on the right, there was a comparison between right colectomy and left colectomy. Here's the results for left colectomy. So once again, this aspect has been widely publicized, and as I said before, in the United States also by Parul Shukla. Other aspects of the cancer have to be considered because the problem with T4 cancers is that very often they are extended cancers and involve other organ resections. Now, it used to be that palliative resections were if you could not envision a radical incision even in the T4 area, this was a contraindication to laparoscopic surgery, but this is no longer an aspect that is considered. And both the NCCN guidelines and the EAS, even though they said even if the EAS did not make any recommendations, they did not say anything against. And as I said before, it's been widely recognized, especially in even recently, that the outcomes may even be better. The size of the tumor with the T4 is something that leads to another specific problem, is the extraction site. Now, the major, let's say, philosophical aspect of the operation would be if you need a specimen incision that is greater than the incision that you would need to do the operation. Obviously, the laparoscopic aspect of doing the tumor resection doesn't make any sense anymore. So this has to be something that's considered. And as it is a multiple stage operation, in other words, the actual resection and then the specimen extraction have to be performed in a very specific manner. It is something that has to be considered in the indication for surgery in the specific situation of a T4 tumor. I mentioned also that there were there was major problems, at least in the consideration for patients, and this is also relative to the obese, in patients that have major problems, heart and respiratory problems. In other words, the ASA 3 and 4 patients. The fact that 15 millimeters of mercury are generally not a problem for patients that are ASA 1 and 2. The low, or let's say the relative low tolerance to high pressure pneumoperitoneum is a indication for lowering the pressure of the pneumoperitoneum to less than 12 in patients that are ASA 3 and ASA 4. The reasons for that is the measurements that have been made on the effect of pneumoperitoneum on the vena cava, the blood return when the pressure is 15 millimeters of mercury is relatively decreased. And in a patient, a high-risk cardiac person who has a low return, a low pressure return, this might be a problem for patients that have heart failure, and which is obviously more prevalent in the elderly and in the patients that are at risk with ASA 3 or ASA 4. The same thing is the effect of the pneumoperitoneum on the diaphragm that influences the metric that is the most affected by high pressure pneumoperitoneum. In other words, 15 millimeters of mercury is the end tidal CO2. And so the anesthesiologist has to take that in consideration. And in those high-risk patients, ASA 3 and ASA 4, they have to maintain actually increase the pressure of the ventilation to counteract the effect of the pneumoperitoneum. And so this has to be taken into consideration. I have talked about the problems of obesity. I will not insist on that. Just a few words now about the overall survival that I talked about in the study of Lacey. Lacey study, as I showed before, looked at the aspect of survival in the T3. And then afterwards in 2004, 2005, Other studies came out with the following data, and I think it's important to insist on these data. They showed that the overall survival was reduced when there was an anastomotic leak, and these papers are very important to consider when you look at the outcomes of survival, and when you think that laparoscopic surgery should have the same anastomotic leakage rate as open surgery. And this is, of course, is something that has to be pointed out. And a very recent paper in 2022 looked at the relative survival after laparoscopic and open surgery, and looked at the survival rates with patients that had anastomotic leakage. The continuous line indicated the patients without anastomotic leakage, where the dotted line indicated the patients with anastomotic leakage. The blue lines were patients with cancer, with CC, with colonic cancer, and the orange lines are the patients with rectal cancer. So you see the indications, let's say the survival rates indicated according to the stage, according to whether they had adjuvant therapy or not. Especially in stage 1, stage 2, stage 3, and the actual influence of anastomotic leakage. So these are things that have to be considered, and we have to be very careful that we don't have an increased excessive death due to the fact that these patients had anastomotic leakage. This paper was a result of almost 65 or 66,000 patients that were included with cancer of the colon, and about 23,000 patients with rectal cancer from the Netherlands. So this has an enormous impact on the literature because of the numbers that were considered and the fact that the registry was very well kept. And the overall conclusion of this paper is that anastomotic leakage has a stage-dependent negative impact on survival, both for colonic cancer as well as rectal cancer. However, even though it's not indicated specifically here, did not show any difference in the local recurrence rate. So there is an impact on the overall survival. There is an impact on the disease-free survival, but there is a negative aspect on the local recurrence rate. The last aspect that I want to talk about in the technical aspects of laparoscopic surgery is the effect of conversion. Now, first of all, there's a big and still a wide debate on what do you consider as a conversion. Some people said that there's a limit on the length of the incision needed for the specimen retraction. At one time, it's very difficult to say whether you use an open access or a single port apparatus for the specimen retraction or not. It was considered as a conversion. Other people have said that the definition should be something like a deviation from the operative plan. It's very, very semantic differences in definition that have been proposed. So it's very difficult to actually evaluate the effect of conversion And in the past, there have been studies that have looked at the actual conversion rate as they influence the different aspects of surgery, considering the duration of the operation, the morbidity, the hospital stay, and the costs. And this study out of Canada was the first to insist on the fact that there might even be an effect on survival. But this was something that was not kept up by further studies, and was not proven by other studies. So conversion is important. We do not know exactly what the aspect is because of the difficulties in the definition. There is certainly a difference between early and late conversion. By that, I mean that early conversion is something that is usually what we call preemptive. It means that the surgeon recognizes that there's operative difficulties and does not want to continue the operation, whereas the late conversions are usually the result of an intraoperative event, whether it's a complication or a adverse event. So this means we have to have a good preoperative workup in order to best select the patients to lower that conversion rate. Training, of course, is something important that is going to lower the conversion rate as well. And in the beginning of your operative career, as we have already alluded to, the obese and the narrow male pelvis are major challenges for the laparoscopic procedure, and they should be avoided to the beginner. So I think I have looked at all the aspects of laparoscopic surgery and from a technical aspect as well. And I have to conclude that laparoscopic colon and rectal resection are complex procedures that require a number of cognitive and technical skills. You have to have the proper skills to perform these operations, and these are acquired by not only by experience, but by work in the lab, training on the simulation models that we have out today. And I cannot insist more on the fact that these problems have to be solved before you take these patients to the operating room. The learning curve is certainly not the place to take care of these patients. So I've finished with my second talk, and I am available for any questions.